Right, hello and welcome back to Madness and Grace. I'm Matt Stanford, and we've been gone for a little while, and we've had a little bit of a change in our staffing here. We have a new producer, and that's Alpha Choi. She'll be working kind of behind the scenes here, and that's who you'll interact with if you have questions or comments about our podcast. And I have a new co-host with me, and that's Dr. Maddie Stiers. Hey, Maddie, why don't you tell our listeners a little bit about yourself?
Sure. Well, first of all, I'm excited to be joining you on the podcast as co-host. Like you said, my name is Maddie Stiers. I work as the Chief Clinical Officer here at the Hope and Healing Center. I am a licensed clinical social worker, and I also have a PhD in social work. I think moving forward in the podcast, we'll have a lot of interesting things to talk about and insights to share, and I'm excited to be hopping on.
Well, I'm great. It's great to have you. I'm excited to have you. Maddie is a fantastic clinician and an expert in trauma, and so we'll really be seeing that as we have our discussions. And we're trying to decide what we should do as a first topic on our 2024 podcast, and we decided to go with borderline personality disorder, which is a disorder that we deal with quite often here at the Hope and Healing Center, but it's also really something that's incredibly popular in just kind of the general mental health narrative out there. I would almost say to some extent on the male side, there's a lot of discussion around narcissistic personality disorder. And on the female side, you tend to hear people throwing out borderline personality disorder. And hopefully today we can kind of give you a little bit of a better sense of what that is and what that isn't, and maybe demystify it a little bit and break some myths around that and give people some hope that might be dealing with that. So just to kind of kick us off, Maddie, why don't we talk a little bit, and maybe you could start with looking at some of the symptoms of borderline personality disorder and how does that manifest in a person's life?
Yeah, so borderline personality disorder, there's same with like narcissistic personality disorder, there's a lot of stigma attached to the name. When you have depression or anxiety disorder, the word personality isn't in there. So there's when you've been diagnosed with borderline personality disorder, a lot of times people go, "Oh my gosh, is there something wrong with my personality?" So some of these personality diagnoses, have a little bit more stigma attached to them because people really internalize it and start to question themselves and their worth. But borderline personality disorder, there's a few hallmark traits that we'll run through. There's obviously a lot more than this, but a big one is instability in relationships. So whether the person struggles with romantic relationships, family or friend relationships, a lot of times they have a hard time communicating and keeping peaceful and healthy relationships going. And there might be a lot of turmoil in those relationships that they do have, and often find themselves ending relationships, maybe in a kind of dramatic fashion, things like that. There's a lot of emotional dysregulation. So whereas a situation might upset someone who doesn't have borderline personality disorder, on a scale of 1 to 10, a situation might be upsetting at a level 2, someone with borderline personality disorder or BPD. So I'll probably refer to it as BPD from here on out. That same situation might upset them at a 8, 9, or 10. And it takes them a lot longer to kind of regulate and come down from that upset or that emotion. So they struggle with regulating their emotional responses to things. A lot of impulsivity in behaviors. So you see people that might be engaging in really unhealthy behaviors, drug use, reckless driving, promiscuity, or other behaviors that might put them or their life in jeopardy or their wellness in jeopardy. Fear of abandonment is another big one. So oftentimes people with BPD have chronic feelings of emptiness. They never feel fulfilled in themselves. And there's this extreme fear of abandonment from everyone in their relationships, which is what kind of causes the instability that they might be experiencing in their relationships. They might experience dissociation or psychosis as well. Dissociation is pretty common. Psychosis is less common, but it can occur. And then self-harm, suicidal ideation is pretty constant across people who have been diagnosed with borderline personality disorder. I know Matt, we talked about splitting. Did you want to talk about that, or you want me to jump into it?
Yeah, why don't you mention a little bit about that, and then I'll talk a little bit about kind of what a personality disorder is in general. Go ahead. What
Yeah.
about splitting? You hear that said a lot these days.
Yeah. So splitting is really when it kind of falls in line with the instability in relationships that I was talking about. It's when a person with BPD idolizes you one day, puts you high up on a pedestal, and then the next day they kind of knock that pedestal out from underneath you, and you're the worst person, and they're extremely upset with you, whether you did something or not. This back and forth between like extreme adoration and extreme upset or dislike towards a person
Right.
can
And
be
it's
really.
extreme. I think that's something that's important for people to understand. It's not just that they like you one day and they don't like you. It's that you are perfect one day.
And
And if
absolutely
you
the
could do,
worst human
right,
ever.
you are the right. You ran, a concentration camp during World War II, kind of horrible person, when literally the day before you were the perfect individual in every aspect. And they truly believe that.
Yeah. And the fear of abandonment plays into that, the
Right.
emotion dysregulation, and then you see it kind of results in the instability in their
Yeah.
relationships. So,
In some
yeah.
sense, you might describe borderline as the core of borderline personality disorder is this sense of worthlessness, that goes along with the idea of the fear of abandonment, but that you have no value, you don't deserve to be loved, that you really are not a good individual, and that ultimately everyone will harm you and leave you. And so there really is kind of this odd self-fulfilling prophecy in it, in that the person builds up a relationship and then destroys that relationship almost in an unconscious attempt to prove to everyone and themselves that they really are as worthless as they think they are. So just to kind of give some statistics on borderline, about 1 to 2% of the general population. Age of onset's kind of late teens to early adulthood. It is diagnosed predominantly in females, about 3 to 1 females to male. It's heavily kind of genetic in nature. There's a high heritability, about 50% of the variations accounted for by genetics. It has a lot of co-occurring disorders: substance use, depression, PTSD, anxiety disorders, eating issues, lots of other co-occurring problems. And so a lot of times it can kind of go kind of unrecognized because these other things are kind of focused on. And, I think probably more disturbing is the fact that about 10% of BPD patients will die by suicide, where 60 to 70% will make a suicide attempt. And as we've talked before, you and I, it's heavily related to trauma. And so you see a lot of BPD clients that have had trauma. And if they haven't experienced an overt traumatic experience in their life, like child sexual abuse or something like that, there's a lot of things like maternal abandonment and stuff like that that maybe didn't just show up, like someone didn't recognize that as a traumatic experience. But this, we'd say personality disorder. So what are we talking about when we say personality disorder? How's that different than another type of mental disorder? So I think the way to think about it is a personality disorder is a long lasting kind of rigid pattern of maladaptive thoughts, feelings, and behaviors. I mean, this is not something that kind of waxes and wanes from day to day or month to month. This is kind of a core aspect of who the person is and how they think and act and behave. Whereas if you think about someone having depression, there are times that they're very depressed, and then there are times that they aren't so depressed, whether they receive treatment or not. And so it kind of comes and goes, and it may be long periods of time, but it comes and goes. Whereas with a personality disorder, it's kind of a core aspect of who the person is and kind of shapes who they are. And that makes it, more difficult to treat oftentimes. In the context of other personality disorders, borderline falls into this, what we call a cluster B, or the dramatic erratic personality disorders. So it's associated with things like antisocial personality disorder, histrionic, and narcissistic personality disorder. And all of those have some common features, like a lack of impulse control and problems with emotional regulation, like you just mentioned a moment ago. So I think, one of the things that I see particularly on the narcissistic side is that people like, a guy is kind of arrogant or kind of a jerk. In fact, it literally happened to me this morning. My wife said that her friend had called or texted her and wanted to know if I thought that this other person that they were dealing with might have narcissistic personality disorder. That literally happened this morning, and I told my wife what I tell a lot of people, and that is, just because you're a jerk or you're very arrogant doesn't mean you have a personality disorder. So, and I see that also on the female side a lot of times, is that, a woman, is maybe overly emotional for some reason, or is involved in some kind of just self-destructive behavior. And then instantly people throw out the borderline personality disorder diagnosis. So let's talk a little bit about how would you distinguish this from just kind of typical mood swings? I know, for instance, you and I see a lot where people confuse this with bipolar disorder, or they certainly kind of get thrown around together. I think there's also, to tell you the truth, I honestly think there's a lot of times confusion because we will use the term BPD, and people will think that we're referring to bipolar disorder when in mental health that means borderline. So what's some kind of, what would be some kind of simple ways that a person might differentiate, say, a borderline personality disorder from maybe somebody who's just emotional?
From someone who's emotional, like I said, you're going to have, everyone has emotions. Everyone has emotional responses to situations. Where we see the emotional dysregulation in BPD, we don't see dysregulation in people who are having an emotional response to something. So having an emotion, being upset, even if you're on a 10 out of 10, maybe something happens and it's warranted. The difference is someone with BPD is going to have a high emotional response, 8, 9, 10 out of 10 for every situation that happens, whether that's good or bad. So we see people with BPD, oftentimes we hear about all of the behavioral struggles and emotional dysregulation, some of the negative symptoms, but they also love really hard. So when they fall for someone and they decide that they are really invested in you, like there's that strong sense of love as well, which can be devastating if things don't work out. But so for someone who has BPD, almost every situation, they're going to have a really high emotional response, regardless of the emotion.
Across relationships. It's not going to just be one relationship.
And they're going to have a really hard time coming back down to baseline from that. So the emotion will last for much longer than a typical person or a person who doesn't have BPD is going to experience that.
And that's a good point. I think what you make of it, this is different from the average person. When a person falls hard for somebody and it takes some time for them to recover, but they have other health relationships, that's just normal. Okay. Or somebody has a falling out with somebody, but they have other normal relationships and it takes some time to recover. Again, that's just normal. But this cuts across all their relationships. And this is pervasive. It's so different than the average individual. And that's what you have to ask yourself. Is this something that I see different than an average individual? This is not just something that somebody just catches like a cold one day. I mean, this would have been there. You would have seen this kind of working its way kind of through. So I think that's a good point that you make there about this kind of average.
And it's really, really because the person with BPD has emotional volatility, and they likely don't have any skills to regulate themselves. Whereas a person who doesn't have BPD has either been modeled or taught or been in therapy to learn healthy coping skills, to be able to go, oh, this is a really difficult, stressful, upsetting situation. What are some things that I can do? I have other healthy relationships to reach out to. I have all these coping skills. Like I know how to take a step back and take a little break. Whereas someone with BPD is going to experience the emotions so intensely, they get dysregulated, and the distress is so extreme that decisions and choices that follow that aren't always the most healthy for them.
Yeah, as you mentioned earlier, when they have that overwhelming distress as a result of that, they dissociate, they harm themselves, they become involved in substance use, they absolutely destroy a relationship. They will just undermine the relationship completely, where there's no coming back. Again, these are extremes we're talking about here. And so, I think another aspect of it is this idea of, we're talking about a disorder. So we're talking about dysfunction. And so the person is not functioning normally in some sphere of their life. And with BPD, we're really talking about relationships here. They might be able to go to work and do okay. I mean, I don't know if they can or not, but their relationships are a disaster.
Even in the workplace, you see that they will struggle with those workplace relationships because you get feedback and criticism at work. And that's something that's really difficult for someone with BPD to navigate. And so they oftentimes are finding themselves unemployed and unable to hold down a job because navigating any sort of relationship is extremely difficult for them.
Well, all of this is related to trauma. And, we mentioned that earlier. And trauma backwards and forwards. I mean, that's what you did your dissertation work on, and you work a lot with women with trauma. But talk a little bit about the effect of trauma on an individual and how that might kind of lead to BPD and how that's associated, because clearly the person is trapped within that traumatic kind of experience or that traumatic thought process, in that this is a desperate defensive mechanism to try to deal with what they don't even realize is what they're dealing with.
Yeah. So BPD is kind of based in the biopsychosocial theory. So as you mentioned earlier, there's some genetic components to it. There's some biological aspect to developing BPD. There's also the social, environmental, and then the psychological components of it. So the trauma aspect of it, or you could consider invalidation like a lower form of trauma, falls into the social and environmental response. Oftentimes people who show up to our center that are looking for support, that we kind of go, oh, borderline personality disorder might be something that's happening here. They've experienced either, like you said, childhood trauma, whether that's physical abuse or sexual abuse or another form of actual traumatic events that they experienced. But oftentimes these people have also experienced just extreme levels of invalidation. And that can look like neglect, which just total parental neglect. They are not being taken care of. They are not emotionally or physically safe in their environment from a neglect standpoint. But even invalidation in a childhood where your parents were present. So invalidation is really when you're being told that your emotional response or the way that you're experiencing a situation is wrong. So parents can do this not intending to hurt their child, but a child spills a cup of milk, like a little child spills a cup of milk, and the child's extremely upset over it. And the parents go, oh my gosh, stop. Like, it's not that big of a deal. Get over it. Like, I don't know why you're so upset. This is kind of an easy example to kind of explain it. But that child then goes, okay, I'm experiencing this emotion, and my primary caregiver, who should be safe, is telling me that my experience is wrong. So if that happens once or twice, we do that as humans, that's not going to harm a child. But continuously experiencing that in childhood, being told that your emotional response or your experience of a situation is wrong by adults and caregivers around you, you're going to start to question your internal experience.
Right. You see that a lot with inconsistency so one time he spills the milk and, oh, don't worry about it, we're just going to clean it up, no big deal. And the next time he spills the milk, the parent just explodes into this. And so now it was like, oh, well, I feel I'm upset. Oh, don't be upset. I'm not upset. Be upset. And so, oh yeah.
Well, and that's really what trauma is. So when you think about sexual or physical trauma that a child might experience, really what's happening is their brain and their body, regardless of how old they are, is saying this isn't right. Like, something is wrong here, whether they can articulate that or not. But the acts that are happening to them and that a person is kind of doing to them is telling them that it's okay, that this should be happening. And so as a young child, that's extremely confusing, right? Like, I'm experiencing this completely different than how the environment is telling me I should experience it. And so there's a huge level of invalidation of just your worth as a human, right? And so that's an extreme level of trauma, and how that can show up as invalidation in childhood, but all the way to just this constant invalidation or confusion of how I should be experiencing situations.
Right.
And really it just leads to a person's inability to trust their own experiences and feelings over time. And as they start to develop ways to cope, whether that's dissociation or people pleasing, or as they move into adolescent, teen, young adult years, engaging in unhealthy coping skills that really ultimately become extremely destructive in their lives. The coping skills start because they work. I'm dissociating because as a child, that helps me in that moment to escape the trauma. Or I'm out drinking and partying because in the moment that's helping me to escape my reality. But it builds and it builds, and ultimately it leads to dysfunction across the lifespan, right?
And that's why you can really start to see that the destruction of the relationship is a defensive mechanism. So, I mean, as you described that there, you can, basically I'm going to destroy this relationship that I overly invested in so that you don't hurt me. I'm going to hurt you. But ultimately I hurt myself. And so as we talk about this, and you've talked several times about coping strategies and ability to cope, and I would say in the context of this, the individual may have some appropriate coping strategies, but we're really talking about something that has a very significant neurobiological underpinning. So as you mentioned, their arousal is so significant and beyond the norm that even normal coping strategies really aren't sufficient. So let's talk a little bit about treatment, and let me just jump in and I'll talk a little bit about pharmacotherapy or using medication, because that's what most people think of when they think about mental health treatment. And then you might talk about DBT, which I know is kind of the gold standard of treatment from a psychotherapeutic perspective. But in the context of borderline personality disorder, there really aren't medications that treat the disorder per se.
No.
What you can do is you can treat the symptoms of the disorder, and you can treat the underlying or co-occurring issues. And so depression, very common with borderline personality disorder. Substance use, very common. Eating disorders, very common. Even anxiety issues. And so you can prescribe medication that will deal with those co-occurring issues that are very helpful for the individual. Because certainly if a person is less depressed, then they're going to be it's going to be a little bit easier for them to go through a psychotherapeutic intervention, a talking therapy. Another thing is that it has been found effective to use medications to try to deal with the impulse control issues in individuals with borderline personality disorder, as well as some of the mood swings. And so much like you would treat bipolar disorder, which is a completely different disorder, so don't be confused, atypical antipsychotics and mood stabilizers have been used with people with borderline personality disorder when they show extreme levels of impulsivity and kind of that emotional lability where they're just kind of swinging around left and right. And so those have been shown to be effective, although you see that used a little bit less so with BPD. You certainly are going to find most of your BPD clients or individuals that you know that they're going to be on an SSRI for depression and anxiety. I mean, that's extremely common and can be very, very helpful. And so, medication can be helpful, but it's not really treating the disorder. It's just kind of touching on some of the symptoms and dealing with the comorbid or co-occurring issues. Talk a little bit about psychotherapy and how that might be effective.
Sure. So I think you mentioned this. The gold standard of treatment for BPD is dialectical behavior therapy, otherwise known as DBT. So this is where we're going to confuse everyone with BPD and DBT. But DBT was developed by Marsha Linehan, and it's a very structured therapeutic modality that really works wonders with people who are struggling with BPD. It can be thought of as a pretty comprehensive treatment. There's a lot that is asked of the clients or the individuals that are going through it. And we here at the Hope and Healing Center and Institute have a DBT program. And so this is one of the therapeutic modalities that we actually implement here. And so we're continuously interacting with this population in this group. And before I jump into talking about what DBT is, I want to say it's one of my favorite therapeutic modalities. Absolutely love it. I love working with people in the program. I see so much change happening with people who go through DBT. I mean, there really is a lot of hope if you can get someone to commit to the program and to the process. So the DBT program here, we have two client components to it, three, I guess. You have the individual session. So the client comes in once a week for their 50-minute session, meet with their therapist, where they work on identifying target behaviors or behaviors that unhealthy coping skills, essentially. And they work to challenge those and change those, adapt them into more healthy ones. We have our skills class which is once a week, and that's for an hour and a half. In skills class, it's not therapy, it's not a support group, it's a class. So everyone in a program comes, and we have our therapists and our clinical team leading the class, and we are teaching actual skills. So it's very much like you're in school. You come in, there's worksheets that we're going through, there's information that we're delivering to them, all related to understanding some concepts that are pretty standard through DBT, and then teaching coping skills. And then they have homework that they go home and they have to actually implement and practice out in vivo or in the real world. And then they come back the next week and report on how it went. And then we do that every week. And they're in our program for about 13 months. The expectation is that the clients come every week. It's pretty rigorous. We also have a support line that individuals can call if they need to just talk with someone outside of the therapy sessions. They can either call their clinician or they can call our support line. And then once a week, our clinical team gets together to support one another as we all work with all of these clients. So we have our consultation team meetings. So those are some of the core components of DBT as a treatment modality. But in skills class, and as we're working through DBT, some of the core concepts that the clients are going to learn and understand is understanding what mindfulness is. People think of it as this kind of like Eastern Zen thing, but really mindfulness is a totally different concept. It can include that, but there's a lot more that goes into mindfulness. They're going to be learning about emotion regulation. So they're learning skills on how to effectively regulate their emotions. They're going to be learning about distress tolerance. So when they get extremely distressed, what are some skills that they can use and implement to help regulate them back down out of distress? And then interpersonal effectiveness. And those skills are really focused on skills that they can use in conversations, in understanding how to get their needs met in effective and healthy ways, how to have healthy relationships, how to end unhealthy relationships, things along those lines. And then that's what they'll learn through skills class. And I think I mentioned during the individual session, they have more homework for their individual session. They come in each week with a diary card that they've filled out that lists out their target behaviors, which could be, binge drinking or getting into screaming matches with their partner or self-harm. And they'll mark how often that's happened. They mark their emotional responses and then some of the consequences of those. And then the therapist works with them to kind of figure out what was the prompting event? What was the thing that triggered this? Let's see if we can throw in some skills to negate you getting to the point of engaging in these target behaviors or unhealthy behaviors, and hopefully implement something a little more skillful that maybe we've learned in skills class.
Very intensive program. And
yes.
I think, one of the biggest problems that I've seen with people with BPD in the context of treatment is that they often really lack self-awareness of their problem. That
Mm-hmm.
their problem is, and as most people try to, their problem in their mind is external, not an
Yes.
internal issue. And so if everyone else would just get everything together, everything would be fine. And so you don't a lot of times see people with borderline personality disorder seeking out treatment until their life has completely fallen apart around them, and their families and friends and loved one and romantic relationships are completely pushing them away. And it's only in those situations oftentimes that they will seek out treatment. And they unfortunately then are seeking out treatment at the worst possible moment. But treatment is effective. So let's talk a little bit to finish out our time about some tips for families that might be dealing with a loved one who has BPD. How can they support that individual? How can they help themselves? I mean, first thing I would say is I think it's really important that you educate yourself about the disorder. I think the more you know about the disorder, the better it's going to be for you. I think it's easier for you not to take the things personally that are occurring if you understand the disorder more. This person has a mental health problem that causes them to be at times rather aversive to be around, and actually at times very mean and hateful. And that can make it very difficult for you to want to be involved in their care. And so you oftentimes will find people with BPD that have very little support around them. It's easy from the outside to say, well, this person just did it to themselves, at not recognizing really what's going on. So I think it's important for families to kind of set up healthy boundaries. And really the only way you're going to be able to do that effectively is if you have a mental health care provider helping you. So it's not a bad idea for you to connect with a mental health care provider yourself, or maybe get in a support group where people are struggling or dealing with the same type of thing, just to kind of help you be able to have some appropriate self-care, keep yourself in a good place so that you might help the other individual. What other things might you kind of suggest, Maddie?
So for parents with adolescents or teens who are in a DBT program, whether the child has been diagnosed with BPD or something else, they've been entered into a DBT program. Oftentimes, places that offer adolescent DBT treatment have a skills group or an additional group for the parents to attend to, because it's as the child's learning these coping skills, parents can learn them alongside them to help foster the development of those. It's also helpful for parents to understand coping skills as well if we didn't have them, if they struggled to work on those. So a lot of treatment places will include the parents, usually when it's a child or an adolescent or teen. But yeah, there's also groups out there that you can join. You can join a skills class group if you're wanting to understand some skills that maybe your loved one is struggling with navigating. I mean, you can join a DBT skills class. It's not all groups require that you have a diagnosis of it, there are groups out there for people who are just wanting to learn and understand some of the skills that they can help, reinforce in their loved one.
I think I would also say, this is a great opportunity for faith communities to be involved in caring for families that are struggling. I mean, it's a great opportunity for them to offer lay counseling or support groups for caregivers. And regardless really of the mental health care problem that their loved one has, but certainly for something destructive or damaging like borderline personality disorder, it's a real opportunity for a faith community to step up and say, we'll walk along with you, we'll help care for you, we'll help take care of your physical needs, whatever those may be, as you try to care for your loved one. So there is hope. I think that's important for us to say. I mean, DBT is very effective. I think, like with most therapeutic interventions, the difficulty is getting the client to hang in there with the treatment, because it can be very painful as you try to remember and process these traumatic experiences. But that's not specific to borderline personality disorder. That's anything that has to deal with trauma. And really, to some extent, any mental health care problem, it can be painful as you go through and learn how to deal with and process these issues. And so, as we finish up today, I would just say, if you're looking for more resources related to DBT or borderline personality disorder, please check out our website, hhci.org. And in the description of this program, you'll find a email if you have questions or comments, or you want to make a suggestion for a future program. Please email us and let us know. And I thank you for joining us, and we look forward to being with you throughout the year here on Madness and Grace.